Video, I'm again discussing a topic that is very important: idiopathic thrombocytopenic purpura. So, idiopathic thrombocytopenic purpura comes on history and also comes on video stations. First, we know the definition of idiopathic thrombocytopenic purpura from the NICE guideline. That is, platelet is less than 100 into 10 to the power 9 per liter, usually less than 20 into 10 to the power 9 per liter. Self-limiting disease with shortened platelet survival and increase the megakaryocytes. Good prognosis. There are three types: acute, persistent, and chronic. Acute is 0 to 3 months, persistent is 3 to 12 months, and chronic is more than 12 months. So this is all about the definition. Where platelet less than 100 into 10 to the power 9 per liter, usually less than 20 into 10 to the power 9 per liter. Then, according to NICE guideline, the signs and symptoms of ITP are acute onset of bruising, purpura, and petechiae, serious mucosal bleeding, unusual, look for other causes. There is preceding infection and absence of, remember, absence of hepatosplenomegaly, lymphadenopathy, evidence of serious cause, chronic underlying illness. So, ITP come on the history, then we know this, the features we'll find. And ITP differential diagnosis we put like non-accidental injury, like PIMS, COVID, leukemia, Hanus-Green purpura, drug reaction, and less likely meningococcemia. So sepsis, DIC we can keep. ITP comes in history. The chief complaints may be either come with bleeding, mucosal bleeding, epistaxis occur, or can be come there is rash in the body, whole body rash. So if it is epistaxis, like come bleeding, then we take the start like a bleeding history, and if it is comes as a rash, then we rash. Normally in history, with DD, we need to exclude what are the history. Will ask the onset, course, and duration, associate with fever or not, fever which occurs fast or occurring fast together. Then the rash is blanchable or not. If not clear in the video, rash distribution and progression, is it itchy? Okay, hematology, we ask about the bruises, epistaxis, or bleeding from other any sites. So that is very important: bruises, epistaxis, or bleeding from other sites for ITP. History of upper respiratory tract infections. There will be history that we'll ask that before what happened, before, during, after. So before, upper respiratory tract infections. Respiratory, we ask that KIPTIA, previous history of upper respiratory tract infections. GIT, about abdominal pain, bloody diarrhea. For differential diagnosis, Hanus-Green purpura. CVS, tachycardia, cold extremities, fainting, signs of shock and sepsis, abnormal gain for Hanus-Green purpura. CNS, we ask about the conscious level and if it's deteriorated. Seizure, sign of meningeal irritations, meningococcemia. Then urinary, color of the urine, and if it's frothy, Hanus-Green purpura, and blood pressure for hemolytic uremic syndrome. So hemolytic uremic syndrome also we can keep in our mind because it also comes on exam. We know the features is there is thrombocytopenia, anemia, and this renal failure probably. MSK, any joint swelling, joint pain because of Hanus-Green purpura. History of contact to COVID patient and immunization status. Fever, weight, activity, sleep. Fever, weight, activity, sleep, very important. Fever, the patient toxic, active or not. Normally, ITP, you know that active patient, but meningococcemia, that is toxic. So for differential, history of any trauma, very important, and history of drug intake, drug reactions, one of our DD. So this is the history we'll ask. Then they ask how can you manage this patient. So after history taking, we'll examine the patient. Rash, if normally we for ITP we are rash package like CNS, fundus, mucous membrane, and the abdomen we examine. And if they are telling that suppose that is a general conditions, we for a rash you need to examine. Then we can tell that after taking complete aseptic measures, wearing protective equipment and gloves, admission and isolation and notification of the infection control team, ABCD and full exposure and painkiller, assess the vital sign and temperature instability, assess the consciousness level in urine output, capillary refill time, edema, Glasgow Coma scale, examination of the rash, glass test, full neurological, cardiovascular, abdomen, chest, MSK and genitalia, Hanus-Green purpura, lymph node examination for malignancy infections, fundus examination and ophthalmology referral, and examination of the joint, MSK examinations. So that is all the DD examination. If only ITP that telling that suppose it is ITP, then we'll tell the rash we are checking, that is blanchable, non-blanchable, CNS, fundus examination, mucous membrane, and the abdomen. This. Now, how can we investigate this case? Investigation, I am from telling the NICE guideline, that is, I will do the full blood count, blood film, and the clotting. Then blood grouping. So full blood count, blood film, and clotting, and blood grouping. If headache and or neurological signs, until CT scan of the head. So if headache or neurological sign, CT scan of the head, bone marrow aspiration unnecessary unless there is neutropenia or severe anemia, hepatosplenomegaly, lymphadenopathy, pallor and lassitude, pain or limb in the abdomen, back, limb. Then we can do the cytomegalovirus or Epstein-Barr virus, immunoglobulin M, if risk factor HIV, hepatitis B and hepatitis C. This is all about the investigation I will do. Now, what is the treatment I will give? Treatment we are giving mild, moderate, and severe case. Mild, very shortly, I'm nicely telling that mild, if normally management is nothing unless life-threatening conditions or significant bleeding, none regardless. And if mild bleeding, we can prescribe just tranexamic acid. It is an antifibrillary adjuvant treatment to control the bleeding. So for mild, tranexamic acid. Moderate, we are giving prednisolone and IV immunoglobulin. But if severe, we are adding here platelet transfusion, methylprednisolone, and IV immunoglobulin. And if chronic ITP, we know the definition of chronic ITP is more than 12 months. Then we are giving the bone marrow, prednisolone and dexamethasone, IV immunoglobulin, rituximab or thrombopoietin receptor antagonist, splenectomy plus advice. Remember, in chronic, we are involving the pediatric hepatologist. We'll discuss with the pediatric hematologist in chronic. More than 12 months is the duration. And giving some advice for ITP patient. What are the advice we are giving? Avoid the contact sports, avoid NSAID, educate them that it can be recurrent and 20% cases, steroid card and bracelet, and also the red flags. What is red flags? Fever with red flags we can give. These are. And subsequent management 70 to 80% resolved in 6 months, favorable outcome irrespective of treatment, avoid contact sports, impossible to prevent fighting, vigorous knock about games at home. Parents can find additional information from ITP. Monitoring the treatment, full blood count and fill monthly until diagnosis clear and recovery. Repeat the sooner if bleeding and increasing the bruising. Discharge and follow-up from niceline, we are telling this. Discharge from long-term follow-up when platelet is more than 100 into 10 to the power 9 per liter and asymptomatic. Advised to risk relapse 20%. None that mother with history of ITP, even if they have normal platelet counts, can give birth to thrombocytopenic babies. So if mother with history of ITP, then can be give birth to a thrombocytopenic babies. And we know that chronic ITP, I already told, advice is same, avoid contact sport and SAID, educate them that if it is recurrent, 20% can take the steroid can bracelet. So this is all about the ITP. It comes on video stations and also history. Thank you very much.